During my freshman year at Brown, I was offered a leave of absence after disclosing to my professor that I was transitioning antidepressants and experiencing severe withdrawal. Somewhere between my senior year of high school and sophomore year of college, I wound up taking 375 milligrams of Effexor, an SSNRI, primarily to treat obsessive-compulsive disorder and mood disorders, in addition to Klonopin, an anti-anxiety drug, and Abilify, an antipsychotic. If I didn't take what I can only refer to as my horse pills at the same time each day, I would experience brain zaps, nausea, migraines, and severe body aches. When I was offered a leave of absence, instead of being asked what support I needed or what the school could do to help, I went into shutdown mode. I thought, they're trying to get rid of me. They flagged me. One wrong move and I'm gone. And at Brown, you've been given an extreme privilege to attend an Ivy League university. Happiness is almost expected. Being social and grateful is expected. You can't exactly go home and tell your mom you haven't read one article on the syllabus, haven't yet been to class in 2 weeks, haven't been able to eat more than one yogurt a day, and your suicidal thoughts are at an all-time high. And especially as a first-generation college student, I can still remember the weight of getting my acceptance letter. So the pressure was on. And if I was going to be able to stay at Brown, I needed to support myself outside of systems of university care. That night, I called my parents in a paranoid, panicked, psychotic state, digging through the internet, researching university surveillance policies when it came to mental illness, and vowing to never use them again if I ever needed help. Well, later that semester, I did need help. I experienced a severe self-harm episode in my dorm room, and I needed medical attention. I knew all of my options: health services, CAPS, after-hours line, Butler Hospital, the emergency room. But what I didn't know is what would happen if I used those services. Would the university find out? Would I be forced into treatment or kept on suicide watch? I remembered my fear earlier in the semester and decided to Scotch tape part of my leg back together and hide in my room for 3 days. I developed a severe infection with raised and purple scars, but at least I was still a Brown student. Now, not everyone would react this way with such initial mistrust, but I had already experienced 4 years of educational bureaucracy in high school and politics when it came to mental illness, as well as my own gaslighting by the medical establishment. And I knew how far those in power were willing to go to silence a potential threat. In 2009, while a freshman in high school, Brittany Marie Petroka lost her life to suicide. We attended different schools within the same district, and our circle of friends overlapped significantly. At 14 years old, our worlds were shook. We didn't have the language, structure, or support systems to be able to support ourselves or each other. When students were denied a memorial service, denied the ability to wear t-shirts with her face and name on them, and denied the opportunity to bring in suicide prevention professionals, I wondered who we were really trying to protect. If at 14, I were old enough to see the body of my friend at her wake, then I was old enough to learn about suicide and have a conversation. And these conversations were happening anyway, behind closed doors, unmediated by friends, on the internet, and awkwardly with family with good intentions, or worst of all, alone, by ourselves. During high school, angered by the response to my friend's death, I began advocating for policy reform surrounding how 7th to 12th grade educators handled mental illness and suicide. After attending endless meetings with the district, I was told I could continue doing my work, but needed to keep my personal politics out of it, something I was never willing or able to do. If they didn't want to support us, we would have to support ourselves. When I founded Project Let's in 2013, we focused primarily on erasing the stigma, as our name very much indicates. But as I later realized that we'd like to imagine a world without stigma, it's still very real for many folks, especially the most marginalized of us. We can tell people all we'd like to seek help, but what does that do to address the traumas they may face once they seek that help? Or what if an individual can't afford their copay? What if we encourage someone to come out as mentally ill and they lose their job or their place in their family? Most mental health organizations focus on raising awareness, and at first, that's what we did too. We believed, like many still do today, that stigma and access to care were the primary problems. My education at Brown and continued life experiences have taught me otherwise. This data from a report on the nature of suicidal crises in college students shows that a mental health professional was least influential in preventing a suicide attempt, far below friends, family, and other social factors like pets. So this told us that we needed a space, unmediated by professionals, where folks with mental illness, trauma experience, and disability could find support for themselves and support for others. And beyond that, we also realized that we were the best people equipped to advocate for policy reform. Nobody knew the intricacies of the system better than we did. And nobody else could provide firsthand narratives to counteract what we were being told by administrators. As my colleague Molly likes to say, universities see mentally ill and disabled students as the baby or the grenade. As the baby, you're asking for too much and being too needy, too many accommodations, exaggerating symptoms, who can be this sick all of the time, right? And if you're the grenade, you're a liability, a risk, and a ticking time bomb. And the grenade metaphor is what most administrators view us as when they are designing policies. Over time, students came to us for help, and we started uncovering alarming consistencies across schools across the nation, suggesting a much more intensive surveillance and risk management culture than we had anticipated, which can be in part attributed to responses in higher education following the Virginia Tech crisis. We became aware of patterns of who was being disproportionately impacted by these policies, such as lower income, international, trans and queer students of color. In addition, we also identified pervasive flaws with the mental health care infrastructure in general, most prominently a short-term therapeutic model that refers high rates of students off campus, a lack of availability, and a lack of diverse representation of providers. And outside of seeking help, a primary issue for me became not seeing myself represented in the Brown student body and in my peers around me. I knew what to Google for an overly simplistic monk-like explanation of what OCD was and how it's all about germs, but I didn't know how other Brown students managed to share their freshman year dorm bathrooms, allow their friends to sit on their bed, or make it through a 200-page novel without needing to read every fourth page 4 times through, which takes hours. I needed to see for myself how other Brown students were surviving with their lived experience. But something else we realized was that nobody truly believes students with severe mental illness can exist at Brown. We're becoming more comfortable talking about depression and anxiety, but there couldn't be any bipolar or schizophrenic students here, right? In my anthropology of mental health class, we read Emily Martin's Bipolar Expeditions. Martin lived with bipolar disorder, and while teaching at Princeton, approached the head of psychiatric services wanting to start a support group for bipolar students. The psychiatrist responded that it would not be necessary, considering students with those kinds of severe problems would simply not be able to function in the intellectually demanding environment at Princeton. And this was in the 80s. But what does it mean for students to function beyond performing academically? Is it simply just medication and a good therapist? For years, the disability community has also been championing a model framework called the social model of disability. It wasn't truly until I experienced my 3rd sexual assault at Brown that I understood the implications and power of this model. With a social model of disability, we could actually make a difference. In my own experience and in my conversations with students and peers, most felt more impacted by stigma, discrimination, and social barriers like a lack of accommodations and acceptance than by their own symptoms. And following this logic, working to remove those barriers could potentially increase our quality of life. Since most of us are entrenched in a medical model of disability, which tells us that the problem is located inside of our bodies, we often ignore very important information and contesting narratives, such as, for example, sexual assault survivors who don't feel like a PTSD diagnosis accurately represents them. Is there really something wrong with me when something wrong has happened to me? Additionally, we know that trans folks with supportive families are far less likely to attempt suicide. So how can we say there's something wrong with them? This framework allowed us to create peer-led interventions that we believe work. Perhaps we can't take away your psychosis, but we can advocate on your behalf to ensure you're receiving the resources and support you're legally entitled to. And maybe for our most vulnerable students, we could help tip the balance in their favor, which is exactly what we've been achieving through the peer mental health advocate model at Brown. PMHAs, put simply, are students with lived experience of mental illness, trauma, and disability, trained to work as peer counselors and advocates for their fellow students. At Brown, we currently have over 85 students consistently using the program and approximately 80 trained PMHAs. Our 6-week curriculum covers everything from relationship building and listening skills to coping mechanisms, crisis response, and trauma-informed care. Now, when you're trying to innovate in the healthcare field or anything marginally related to science, you need evidence. I don't just expect you to believe me because I'm mentally ill. PMHAs have their own defined role. We're not therapists. We're advocates, supporters, change agents, and more. We draw on our life experiences in an intentional way to inform our actions in each of these roles. Primarily, we want the folks we work with to find ways to heal and move forward on their own terms. Research from Mental Health America also shows that peer support benefits providers as well as patients. Decreased hospitalizations and shortened stays in inpatient care translates into financial savings, which doctors really like to hear. And in addition, embedding peers within the system allows providers to appreciate alternative views of folks with mental illness, functioning in social roles as opposed to always just being the ill patient. There are specific psychosocial processes that have been identified in terms of peer support and help us to understand how it's working. In terms of social support, we provide peers with an available person they can rely on, who's willing to assist and meet their needs while combating isolation. Experiential knowledge refers to a specialized information and perspective that folks can only gain by having that lived experience. Social comparison theory at its core means representation. We need to see ourselves like others to know that we can survive. And most importantly, for us, is helper therapy principle. Put simply, helping others helps us. And we have witnessed this time and time again. Those who may be consistently poor supports for themselves are the most skilled advocates we have. A few weeks ago, I had a severe self-harm episode in my apartment, much like freshman year. Except this time, I wasn't alone. This time, even as someone chronically resistant to treatment and allergic to asking for help, I reached out to one of my own peer mental health advocates and was supported like I never have been by one of my professional therapists. I was treated with dignity, autonomy, kindness, and compassion. I was asked what I wanted and was assumed to be able to make my own decisions. These are the lessons that peers with lived experience can teach the professionals. I want to challenge us to think of what a world would look like where we don't call 911 on suicidal people or lock them up for disobeying commands they may be unable to follow in the first place. What would a world look like where we took accountability for our loved ones and our community members and trained ourselves in crisis intervention and de-escalation skills, where we were able to create inclusive spaces and institutions that allowed all types of folks and all types of neurodivergent minds to thrive, where we were able to look at our mentally ill and disabled friends who reach out in a time of support and say, "Thank you for telling me. What does this mean for you right now? How can I help you feel safe?" Where we recognize that even though I do not have a PhD, I am the expert of my own mind and body. A world where we value the knowledge produced by folks with lived experience, center our voices, and integrate our solutions and systems of support into the larger mental health care system. So no college student ever responds to a self-harm episode alone in their dorm room again. And so we can get to college in the first place. Thank you.